Good morning, students. So today's topic of our lecture is pulmonary function test. Pulmonary function testing is valuable tool for evaluating the respiratory system. Comparing the measured values for pulmonary function test obtained on a patient at any particular point with normal values derived from population studies. The percentage of predicted normal is used to grade the severity of the abnormality. Pulmonary function test, it evaluates one or more aspects of the respiratory system. PFT, that is pulmonary function test. Core lungs components include the airways, large and small, lung parenchyma, alveoli, and interstitium, and pulmonary vasculature, the balloon pump mechanism. PFTs can include simple screening, spirometry, flow volume loop, formal lung volume measurement, bronchoprovocation testing, diffusing capacity for carbon monoxide and arterial blood gases, measurement of maximal respiratory pressures. These studies may collectively be referred to as a complete pulmonary function survey. Spirometry, measurement of the pattern of air movement into and out of the lungs during controlled ventilatory maneuvers. Often done as a maximal expiratory maneuver. Its importance. Patients and physicians have inaccurate perceptions of severity of airflow obstruction and or severity of lung disease by physical exam. It provides objective evidence in identifying patterns of disease. Spirometry. It is simple, office-based, measures flow, volumes, volume versus time. It also uses to determine post-expiratory volume in 1 second, that is FEV1, post-vital capacity, that is FVC, FEV1 by FVC, post-expiratory flow 25% to 75%. The most readily available, most useful pulmonary function test, it takes 10 to 15 minutes and carries no risk. Spirometry is the most commonly used lung function screening study. It should be clinician's first option. Other studies being reserved for specific indications. It is easily performed In the ambulatory setting, physician's office, emergency department, or inpatient setting. Patient care and preparations. Two choices are available with respect to bronchodilators and medication use prior to testing. Patients may withhold oral and inhaled bronchodilators to establish baseline lung function and evaluate maximum bronchodilator response, or they may continue taking medication as prescribed. If medications are withheld, a risk of exacerbation of bronchial spasm exists. The slow vital capacity can also be measured with spirometers. Collect data for at least 30 seconds. When airways obstruction is present, the forced vital capacity (FVC) is reduced and slow vital capacity may be normal. When the slow or forced vital capacity is within the normal range, no significant restrictive disorder. No need to measure static lung volumes, residual volume, and total lung capacity. The indications, diagnosis, evaluation of signs and symptoms include SOB, that is, shortness of breath, exertional dyspnea. It is the dyspnea on exertion is the sensation of running out of the air and of not being able to breathe fast or deeply enough during physical activity. It can be treated by antihistamines, dialysis, diuretics, medications to lower blood pressure as well. And next is chronic cough. A chronic cough is a cough that lasts 8 weeks or longer in adults or 4 weeks in children. A chronic cough is more than just an annoyance. A chronic cough can interrupt your sleep and leave you feeling exhausted. Severe cases of chronic cough can cause vomiting, lightheadedness, and even refracture. Screening at risk population. Monitoring pulmonary drug toxicity. Abnormal study include CXR. Now, what is CXR? It is chest radiograph, EKG, ABG, and hemoglobin. Next is preoperative assessment. Evaluation of signs and symptoms, as you have seen, exertional dyspnea and chronic cough. Screening at risk population, monitoring pulmonary drugs, abnormal study, CXR, EKG, ABG, and hemoglobin, preoperative assessment, assess severity, follow response to therapy, determine further treatment goals, referral for surgery, and disability.